Hello everyone and welcome to MedSurg 1, Chapter 27, Caring for Clients with Hypertension. And here are your learning objectives for Chapter 27. Identify the components that create blood pressure, list factors that influence blood pressure, list three structures that control the arterial pressure, explain systolic and diastolic arterial pressure. You should be able to discuss the potential value in assessing central aortic systolic pressure, define hypertension, and identify those groups at risk for it. Know the difference between essential and secondary hypertension. You should also be able to identify the causes of secondary hypertension, list consequences of chronic hypertension. You should be able to discuss the assessment findings in hypertension, discuss the medical and nursing management of a client with hypertension, the differences between accelerated and malignant hypertension, identify potential complications of uncontrolled malignant hypertension, and discuss the medical and nursing management of a client with malignant hypertension. So this is a list of words you need to know, essentially the medical terminology that's needed when discussing hypertension. So guidelines for hypertension are always changing, and this video provides a view or a different viewpoint towards those guidelines. And this is just for you to refer to or look back at just to get a comparison. For NCLEX purposes, refer to your book. So blood pressure is the force produced by the volume of blood in the arterial walls. It is the cardiac output times peripheral resistance. The heart and blood vessels work together to create the blood pressure. Now, blood pressure is affected by age, which is not modifiable, body size, diet, activity, emotions, pain, position, gender, time of day, and disease. So it's very important to use the correct size cuff when you're obtaining a blood pressure. So you want to determine ahead of time if you need a large or standard size or even a small blood pressure cuff to obtain the most correct reading for that patient. Now the body regulates blood pressure all throughout the day, and the components that do that are the autonomic nervous system, the kidneys, and the endocrine glands. These all regulate that arterial pressure. Now, blood pressure increases with age due to arteriosclerotic or atherosclerotic changes in the blood vessels or some other effect such as a chronic disease like diabetes or renal failure. So, systolic BP is determined by force and volume of blood that the left ventricle ejects during systole and the ability of the arterial system to distend at the time of ventricular contraction. Arteriosclerosis causes vasoconstriction, which increases peripheral resistance. This in turn increases the systolic BP. You'll see this lots of times in older clients due to arteriosclerotic changes. So the diastolic pressure is determined by the arterial pressure during ventricular relaxation. If arterioles are constricted, blood is under greater pressure, that causes an elevation in the diastolic pressure. So hypertensive disease is also known as a silent killer. This is due in part because oftentimes there are no symptoms. Clients may be totally asymptomatic with their hypertension. But there are some serious complications or consequences associated with hypertensive disease. For instance, the size of the heart muscle can increase. When this happens, a client can suffer from congestive heart failure. Myocardial ischemia can result in myocardial infarction, angina, and dyspnea. Hemorrhage of tiny arteries in the eyes can also occur. This can lead to blurred vision, papular edema. Cardiac failure can also happen as a result of the hypertensive disease. CVA, or cerebral vascular accident, which is also known as a stroke, can occur as a result of hypertension. Renal failure. So anyone who has that hypertensive disease are at risk for developing renal failure. And of course, coronary artery disease. Now, getting back to the stroke. So a stroke occurs when vessels in the brain can rupture and bleed. So say there's a little aneurysm that's developed, and that aneurysm begets larger and larger and larger because that hypertension, that blood pressure, is just going at such a high resistance there in those vessels. It can actually cause a rupture, which can lead to hemorrhage and shock. So stroke is very common, unfortunately, with hypertensive disease, and that's why whenever someone has those risk factors or some pre-hypertension, we want to go ahead and start modification as early as possible to prevent something like a stroke from happening. So an elevated BP causes a cardiac abnormality. During physical assessment of a client with hypertension, you would expect to find a sustained increase of either or both systolic or diastolic measurements. So first of all, we have hypertensive vascular disease, and this is when vascular damage is present without any heart involvement. Then you have hypertensive cardiovascular disease, and this is when you have both heart disease and vascular damage that accompany hypertension. So hypertension or your high blood pressure is divided up into stages. You have the pre-hypertensive stage. This is when the systolic blood pressure is 120 to 139 or diastolic of 80 to 89. Now, during the pre-hypertensive stage, this is when you want to teach the patient about reducing those modifiable risks. They want to change their diet. They want to lose weight. They want to stop smoking. You want to encourage exercise, that kind of thing. You want to start those modifiable changes without medication therapy during the prehypertensive stage. Stage 1 is a systolic of 140 to 159 and a diastolic of 90 to 99. Your stage 2 is systolic greater than 160 and a diastolic equal to 100. So hypertension is divided into two categories. The first is essential hypertension. This is also known as primary hypertension, and often it is idiopathic in nature, meaning that there is no known cause for this high blood pressure. And you will see this in 95% of the cases with hypertension. Secondary hypertension, our second category, is when the blood pressure is elevated as a result of a secondary or underlying disease process, such as renal disease. Now, you need to understand that a single elevated blood pressure does not confirm hypertension. You need to have your blood pressure reassessed several times before that diagnosis is made. So just know that when a client comes into the clinic or the doctor's office and you have one hypertensive episode, that does not mean the patient has high blood pressure. You need to do some consistent and readings over and over again before you make that definitive diagnosis. Now, understand that sometimes you have what's called white coat hypertension, and that's when the blood pressure is elevated just because the doctor walks in the room or even a nurse. You go in to take somebody's blood pressure, they're always anxious and nervous, and their blood pressure goes up. So you may have to do a few little techniques to get that patient to relax and calm down so that you can take blood pressure and get a good accurate reading. So now let's compare the two categories, essential and secondary hypertension. So the causes of your essential, remember we said it's idiopathic, sometimes there's not any known causes. Sometimes it can be related to age or it can be a family history. And African Americans tend to have the highest or the greatest risk for hypertension. So now your risk factors for your essential hypertension or your primary hypertension is obesity, inactivity, smoking, stress, hypernatremia. Now, hypernatremia is elevated sodium levels, and when those sodium levels increase, that increases the blood volume, and that's what increases the blood pressure. The kidney's response to the elevation of the blood pressure is to excrete more sodium and excess water. Any retention of sodium and water is what increases the blood volume, and that increases the blood pressure. So we want that sodium and that water to move together. Hyperlipidemia, alteration in body chemicals, impairment in renin angiotensin aldosterone mechanism, which of course is our renal, high intake of sodium and saturated fat, and postmenopausal women. So you want to make sure that you are telling that client or instructing that client, I should say, you should suggest to that client to stop smoking to reduce that risk of any hypertension, because nicotine increases the heart rate. That constricts the arterioles and that reduces the heart's ability to eject blood effectively. So it's really essential that we do a lot of teaching, especially with that essential hypertension, because we want to make sure that we can reduce those risk factors that are modifiable, right? And you want to do that early in that pre-hypertensive stage. That's when you want to do the greatest part of your teaching is to get that under control, and hopefully the client can avoid any medication at that time. Now, our secondary hypertension, that is the result of a primary condition that can affect fluid volume, such as renal. So your risk factors for this are kidney disease, phenochromocystoma, excessive catecholamine release, hyperaldosteronism, Cushing's disorder, which is an excessive glucocorticoid secretion during that time, atherosclerosis, cocaine use, cardiac stimulants, oral contraceptives, brain tumors, encephalitis, and even pregnancy. These are the risk factors for your secondary hypertension. Now, note if you get these risk factors because they are secondary, if you get them under control or taken care of, such as after the woman has the baby, her hypertension may go away completely. She may not have any problems with hypertension again. You get that Cushing's disease under control, then you are going to have that blood pressure under control as well. Now, that phenochromatocytoma, that's a benign tumor that's on the adrenal medulla. So removal of that tumor can essentially make that secondary hypertension go away. So know that your secondary hypertension is caused by something else primarily that's going on. Just kind of keep those two primary and essential separated that way. So what are the assessment findings on your client that comes in with hypertension? So they're going to complain about a throbbing or pounding headache, dizziness, fatigue, insomnia. They could feel nervous or irritable. Nosebleeds. I've seen quite a few nosebleeds with hypertension. Flushing, fainting, nocturia. Retinal and visual disturbances. So know that when a client has some long-standing hypertension, that's when the blood pressure damages arterial vascular system. As a client advocate, you must really instruct on not only prevention but also on early identification of complications such as those from this list, these assessment findings. So damages can occur to those tiny arteries that are in the eyes, and that can compromise the client's vision. So it's really important to instruct the client to maintain regular eye appointments so that they can hopefully not have any damages with their eyes as a result of that hypertension. So how do we go about diagnosing high blood pressure, hypertension? How do we do that other than consecutive blood pressure readings and the patient's signs and symptoms? Well, we can do electrocardiography. We can do chest x-rays because we're looking at enlarged ventricles. We can do what's called MUGA scans. We can do blood tests. We can look at that renal function, look for that elevated BUN, those elevated serum creatinine levels, serum and urinary cortisol levels. We can look at that blood glucose to see if that diabetes is under control. And we can also look at those cholesterol levels. So we've got a few tests that we can do. Like a 24-hour urine collection is a specimen that's ordered, and it can determine dysfunction of the adrenal glands. It's a urine specimen that's collected over a 24-hour period that detects elevations in the catecholamines that are released in the urine. So that can lead us to those cortisol levels that may be elevated that could be causing that high blood pressure. So sometimes you want to find not only confirm the high blood pressure, but maybe seeing an underlying cause of the high blood pressure. So management of high blood pressure consists of both non-pharmacological interventions, which you would instruct the client in with pre-hypertension, such as weight reduction, decreased sodium intake, moderate exercise, stop smoking and alcohol use. So lifestyle changes are really beneficial in the management, especially the non-pharmacological management that you would do for a client with that pre-hypertension. So now if you have a client with hypertension and they are unable to lower their blood pressure with lifestyle changes, sometimes they need to be placed on medication. One of the very first medications you're going to place that client on is a thiazide, which is a diuretic, and we use that usually first. Hydrochlorothiazide, which is HCTZ, that's the abbreviation for that, is usually ordered first. However, most people with hypertension will need 2 or more antihypertensive medications to reduce their blood pressure. A possible effect of all hypertensive medications is postural hypotension, which can lead to falls. So, teaching should include tips to manage syncope and dizziness. So, you need to emphasize to the client to maintain safety, like sitting up on the edge of the chair or sitting up on the edge of the bed, kind of getting their balance before they stand. They need to rise slowly. And doing so will help reduce the possibility of falls related to that postural hypotension. So, nursing management of hypertension is a lot of teaching. That includes diet, medication, self care, reduction methods. Nursing is responsible for a variety of management techniques for hypertension. So, deviation from the therapeutic protocol, which means they stop taking their medication, is a significant problem with people with hypertension and other chronic conditions that require lifetime management. An estimated 50% of clients discontinue their medication within 1 year of beginning to take it. So you have to keep that in mind, that a client with high blood pressure may stop taking their medication at any time. And they may not come back to the doctor at all to get more counseling or to get a change in a prescription. So you have to understand that teaching on those first initial visit is key. So you want them to be compliant when they take their medication. You want them to be compliant with diet. You want them to be compliant with those lifestyle modifications. So you want to instruct the client to take the blood pressure in both arms if they can. You want to question the client about their regimen, such as how do you prepare your food? What types of food do you eat? Those kind of things you want to kind of do that therapeutic communication to kind of get in there so you can have an understanding from the client side, so you can offer suggestions on those lifestyle modifications. Stop hypertension with the DASH diet. This is an excellent video for those of you who are not familiar with the DASH diet, which is the dietary approach to stopping hypertension. It's a really good techniques for self-management, and it's presented by a dietitian. So it's an excellent teaching tool. But like I said, that non-compliance, that deviation from that therapeutic regimen is probably 50% or more of clients we see that with. So teaching is essential, especially in that pre-hypertensive stage, because we want to avoid progression to stage 1 or stage 2. So we have what is called accelerated and malignant hypertension. Now, with these situations, consequences, if left untreated, can be devastating. So, clients with both essential or secondary hypertension can develop accelerated hypertension, which is a markedly elevated blood pressure accompanied by hemorrhages and exudates in the eyes. Malignant hypertension is untreated accelerated hypertension, and this is dangerous, and it can accompany papilla edema. Untreated hypertension is the most common cause of malignant hypertension, and this is an emergency. I'm talking about blood pressures where the systolic is over 200. Well, that diastolic is well over 100. So you'll see a client with a blood pressure of 210 over 130. So this is a dangerously high blood pressure. It is a critical situation. So, malignant hypertension occurs in clients with undiagnosed hypertension or those who fail to follow up or comply with medical therapy. It can be abrupt in onset. If untreated, severe symptoms and complications follow rapidly. Malignant hypertension is fatal unless the blood pressure is quickly reduced. Kidneys, brain, and heart may be permanently damaged. Arterial vessels may rupture or they soon will. Retinal hemorrhages may lead to blindness. Stroke can occur. If there is an aneurysm present, it can burst and cause hemorrhage and shock. Pulmonary edema or an MI can occur, as well as renal failure. The goal of treating the malignant hypertension is to lower the blood pressure within 1 to 2 hours. We do this with IV medications such as Hyperstat, Nipride, or Labetalol. Sometimes even nitroglycerin is used IV. For less critical clients, we may use some oral medications such as Precardia or Capitan or Minipress. We're also going to give them some oxygen to reduce that hypoxia that can be induced by tachycardia if they're experiencing that. So whenever you are administering those IV medications, the priority is to monitor the client's blood pressure every few minutes. So you want to make sure that you're using an automatic blood pressure machine to do that, because you're going to have to take that blood pressure like every 5 minutes while you're trying to get that blood pressure down. And you're going to record that in the assessment findings. But you have to use some type of automatic blood pressure system or management during that time of the IV administration of those drugs. So when it comes to the nursing care for the client with malignant hypertension, you need to make sure that you're calculating that dosage carefully. You need to make sure that you're mixing it appropriately. Check the site, the IV site, look at the progression of the infusion. You have to monitor that pretty frequently. Report systolic blood pressure of 160 or higher or diastolic of 115 or higher immediately. Restrict the client's activity during that time as well. Monitor for any neurological, cardiac, or renal complications that can occur while the client is experiencing the malignant hypertension. Always keep emergency equipment and emergency drugs readily available in case of complications. Here on this slide, there's a link to a video in which a client is being treated for a hypertensive emergency. Look at that video. There's a lot of really good information on that video. So thank you for joining me today as we reviewed hypertension. The mind is like a parachute. It doesn't work unless it's open. So keep those minds open. Have a great day.